there is small posterior malleus crack. So if we put only seriously, do I need to fix the posterior malleus?
Again, important question which actually he answered. There's a beautiful slide from his side. Again, I will take an opportunity. If you are fixing syndesmotic screw, you may get away by not fixing posterior malleolus, but that is an indirect reduction. That is not a direct reduction. So, whenever possible, try to fix. He mentioned nicely. Try to fix posterior malleolus. Why you want to fix it indirectly? Till this time, our knowledge was short. We were not having CT scan. That's why we were putting that screw. But it is like indirectly. So when I will do it, when posterior malleolus is very small avulsed fragment, and really going there is of no use. What is another challenge which Dr. Kharu will accept? If it is a small thing, you open here, you will never see a fracture there. Why? Because there is a thick sheet of ligament which is posterior inferior tibiofibular ligament. So it is a challenge. Sometimes I put a screw here, but it has missed the fracture. Okay, so you can put it that time, fix it indirectly by synthesis screw, but it is a indirect reduction. It is optional. Best is, as he said, fix the posterior malleolus as far as possible directly. Posterior malleolus fixation is done for two, three things. One, for the sake of articular congruity. Two, for the sake of reconstruction of the tibial notch for fibula. And third, for the sake of syndesmotic stability. It is very important. Understand its three relations. One, for the sake of ankle congruity. Second, for the reconstruction of notch for the fibula. Because again, for syndesmosis, this notch is important, isn't it? If that is gone, then the notch is not there, and then syndesmosis will be unstable. And third, for the sake of insertion of posterior inferior tibiofibular ligament. So his talk was most important. He mentioned all those points very nicely that you can do it, but issue is posterior malleolus fixation is most essential for these two, 3 points. So why to fix it indirectly with syndesmosis? After fixation of posterior malleolus, also still there is chance that syndesmosis may be unstable. That time you put a
prophylactic.
Any other question?
I have a question.
Last man is asking here.
Just one thing. So just as a continuation to that, okay? Just a continuation to that. So the situation is you have a fibular fracture, you have a posterior malleolus fracture, and you suspect a syndesmosis injury. Okay? So the question is now, how do we do this? Right? What is the sequence so that we actually address every single possibility there? So if you think about it, with all the information that we have, if you fix the lateral malleolus first, okay, which is probably the easiest thing. Number one, you already know that there's a posterior malleolus, so you have gone through a posterolateral incision. Okay, so once you have fixed the lateral malleolus, then because you've already opened it, you can actually see the stability of the syndesmosis by doing a test. So it's direct visualization, right? So you say it's unstable, and you know that there's a posterior malleolus. So the next thing to do is, rather than do an indirect sort of fixation, you fix the posterior malleolus. Okay? So now what you're saying is, theoretically, you have addressed the avulsion fracture of the posterior malleolus with an intact posterior inferior talofibular ligament. Right? So once you have fixed those, you test the syndesmosis again under direct visualization. If it doesn't open up, then it's all fixed. No syndesmosis required because the IPFL is.
We'll have enough tea now.
Okay.
So no question now. We'll have more time to discuss. Well,
right.
Just gentlemen, you were asking one just single precise question.
If it is a late case, let's assume patient presented after 6 months or 1 year after injury. How
he or she will witness. Yeah, actually, that is a not uncommon scenario in our part. Late presentation is very important and one should know. Now, again, in late presentation, we should know all the components of injury because in late presentation, we tend to forget again posterior malleolus. Okay, and we have sometimes in late presentation, we have some challenge to mobilize them. Okay, so in late presentation, what happens is because of anterior posterior subluxation, they lose the length. So when you get the length, soft tissue healing is also an issue. So first, in late presentation, diagnose it completely, what all has gone, whether posterior malleolus has gone, whether fibula has gone, and most of the times you will notice that fibula is malreduced. Most of the time. Most of the time. Okay. So malreduction of fibula is an issue, but after reduction you are going to gain the length. That time you see if posterior malleolus is there, take appropriate approach and release the posterior malleolus and then fix it. But for that, you should know that ankle cartilage is good. In 6 months, in our patients, usually cartilage is good. So even osteotomy, which I will show you some of the cases, even if you do osteotomy after 3 months, 6 months, still you can salvage the ankle. We'll have.
Okay, gentlemen, let's go. Let's come. Let's come and have some tea.